Next session is on, we just discussed about, segregating MetALD, MASLD, and ALD. Next is on the new entity called MetALD. This is presented by none other than Professor Ajay Duseja. Needs no introduction to Indian liver audience. He is our Secretary General of INASL, Head of Hepatology at the prestigious PGMR. Over to you, sir.
Thank you, Dr. Hari. And at the outset, my sincere thanks again to Hope Initiative, Professor Chaudhary, and the whole team. I've been covering this subject for, some of the last few meetings. So before I think we go on to the subject, let's have some two poll questions from the audience. So let's see how much of you understand. As I said, we have been covering this for last few meetings. So what is the definition of MetALD? Please go to your voting pads as per the Delphi consensus which came in 2023. So is it alcohol intake? This is for females and this is for males. 20 to 30 gram per day, which converts into 140 to 210 gram per week, males, females. Or is it between 20 to 50, 20 to 50 or 30 to 60? Or is it more than 50 or more than 60 or none of the above? So can we have the votings, please? So I think at least 53% are right, that this is between 20 to 50 for females and 30. We'll come down to that. Let's go to the next question. MetALD, which we are going to discuss in the next 12 minutes, it has increased severity of liver disease, HCC, decompensation, mortality, then MASLD and ALD both. Same severity, then MASLD and less than ALD. Less severity, then MASLD, and less than ALD. So what are your choices? Or none of the above? Let's go to the voting, please. Again, I think around 70% are correct that this is this is more than MASLD and maybe less than ALD. Okay, let's go to the next slide. So, this entity, as I said, was coined by this Delphi consensus, which we know came in 2023, where, arbitrary figures they took, which we just discussed, based on the alcohol, and we'll come down to that again. So, again, MASLD came as a new entity. As I said, MetALD also came as a new entity, so people started worrying that what will happen to the whole data which has been accumulated on NAFLD. Do we need to repeat all that? But then many people did those retrospective analysis, and we also looked at our ICOM-D data, and we found that majority of the patients, those who are NAFLD, would have one or the other metabolic dysfunction, and more than 95% actually were qualifying to be called as MASLD. So obviously, I think those studies need not be repeated. But as I said, MetALD is a new entity which came from that Delphi consensus. This needs to be refined and need to be understood well, and obviously we need data on this. I mean, in clinical practice, we used to see these kind of patients in real life, that those who had steatotic liver disease, so-called NAFLD that time, and then they were consuming some amount of alcohol. But this, as I said, this entity came now, and I'll just briefly in 10 minutes take you through that how do we define this, what is the epidemiology and the clinical profile of this entity, what is the severity of this entity, and finally natural history and treatment. I think there's a panel discussion after this. Probably they will be discussing about the approach and the treatment in this. So this figure, again, cartoon you have seen now multiple times. So anybody, as I said, females less than 20 grams or males less than 30 grams has steatotic liver disease with metabolic dysfunction are so-called pure MASLD. Anybody who has alcohol more than 50 gram for females and 60 gram for males will qualify for ALD. So it is the in-between 20 to 50 gram per day for females, and 30 to 60 gram is arbitrary, has been defined. But then we do have some patients with alcohol, rather this is very common in our part of the country, where you have ALD and they do have metabolic dysfunction. So this is now being called as ALD with metabolic dysfunction. And I think Ashish is here. Dr. Ashish has given this, a new entity to this, and he wrote this as a letter to editor very recently, and he said that if you're calling this as MetALD, why not call this as ALD Met? But then I think this needs more refinement, so I'll not be discussing more on this, but I think what we will be talking today is on the MetALD. So once, as I said, this entity came in, people started analyzing their data. So let's first look at that, how common is this entity in clinical practice. So if you look at all the incidental steatotic liver disease data, and this is one of the largest and the first which came from UK Bank German study, large number of patients, and all of them had MR PDFF. So 30% had steatotic liver disease defined by MR. Of them, majority is MetALD. I'm talking of incidental steatotic liver disease. Of them, majority would be MetALD. Around 10% is so-called MetALD, and incidental steatotic liver disease, ALDs will not come to you like that, will be only, ALD. And again, further, if you look at this, I think this is all understandable, but then this is, as I said, one of the largest from the UK Bank, where they said that, yes, if you look at their anthropometry and their metabolic risk factors, obviously they are more in MetALD, less in MetALD, but yes, enzyme elevation, AST-ALT, and obviously gamma GT, which can be taken as a marker for alcohol use, is more elevated than MetALD, and the other metabolic profiles, HDL, HbA1c, and triglycerides are more abnormal in MetALD. Then came this, study from Korea, which in addition, again, almost similar figure. The commonest was, as I said, MetALD amongst all the SLDs, followed by MetALD around 10 to 20%, and the least was the ALD. These are again general population screening incidental steatotic liver disease patients. But then they looked at, based on the MR elastography, what is the severity of this MetALD? Is it going towards MetALD or is it going towards ALD? And what they found was that MetALD was going more towards ALD. So it has a severity, as we said in the question, is that it is between MetALD and ALD. So it is less than ALD, but more than the MetALD. As I said, the data is not there for MetALD, so people then started looking at that. Yesterday we had this panel discussion and the debate on the use of NITs in patients with MetALD, and most commonly used NIT we know is the FIF4. So this particular study looked at the utility of FIF4 in assessing advanced fibrosis. So is it as good as you have in MetALD, or do we need some more biomarkers to look at the severity? So this particular study, again, MetALD, MetALD, and ALD, they looked at the accuracy of FIF4 and NFS, and what they defined advanced fibrosis was based on MR elastography, which is a value more than 3.6 kilopascal on MR elastography, and they looked at the accuracy of FIF4, and they found that the FIF4 was close to around 80% accurate in assessing, which is almost, in MetALD also the accuracy of, the FIF4 is close to around 75 to 80%. So which means that I think we can use probably same FIF4 and these biomarkers, which we have been using for MetALD. Now, what happens to these patients over a period of time? Somebody has MetALD versus MetALD and ALD. So as I said, again, some data on the natural history, and this is one of the recent studies from the Odense University, Denmark. This is from a paper from Dr. Alexander Craig's group. And what they divided these patients from, those who are taking alcohol and their last 3 months based on the last 3 months alcohol intake, and then they followed them up, and then they looked at how many had decompensation and how many had mortality. So again, the decompensation rates in MetALD were between MASLD and ALD. So, as the severity is also in between, I think the risk of decompensation is also in between. Similarly, when it came to mortality, this is also between MASLD and ALD. So the MAT-ALD is in the spectrum in between the MASLD and ALD. This is a more recent paper published, again a Korean paper published in American Journal of Gastroenterology. Large number of data. These Koreans are very good at maintaining this general population data. And then they looked at, in addition to the liver-related mortality and the all-cause mortality, which as I said was MAT-ALD had in between MASLD and ALD, they also looked at the occurrence of HCC in them. And again, the risk of HCC, if you look at the figures here in MAT-ALD, was in between MASLD and ALD. So this is in the spectrum of steatotic liver disease. MASLD would be least severe, ALD would be most severe, and MAT-ALD comes in between. And this is in reference to the risk of decompensation, HCC, and overall mortality. I'll just spend maybe not 2 minutes that how should we approach these patients. As I said, there's probably a panel discussion after this. So we need to tackle both their metabolic dysfunction and their alcohol use disorder. So the problem is, I think you just heard this beautiful talk by Professor Nagachala Sani, that this assessment of alcohol can be a problem. And as I said, these are arbitrary figures which have been given by this Delphi consensus. But how do you assess? How do you assess and how do you know that patient is consuming that amount of alcohol? And the second problem in alcohol use assessment is the dynamic nature. Today, somebody could be consuming an X amount of alcohol. I think later, he or she could be consuming a Y amount of alcohol. So I think it's a dynamic thing. So it's difficult, but then, as I said, you need to tackle both. And for that, I think what is required is what we call the integrated approach. Both, alcohol use disorder, counseling clinics, metabolic clinics, we have that at the institute with us, and the role of, obviously, the preventive hepatology. But one thing which I would like to say, and I'd like to quote this very recent study, again published in JHAP, which actually said that, yes, MAT-ALD is bad at increasing your fibrosis, but look at this moderate and even low amount of alcohol. Even that is affecting your increased risk of fibrosis, which means that even if you're consuming alcohol which is less than the limits described for MAT-ALD, that can also increase your risk. So which means that no amount of alcohol is safe or good for those who have steatotic liver disease. So I think this is a very important paper and very important information. Now, as I said, alcohol assessment is a problem, and again, you heard about the biomarkers. So people are suggesting that whether we can use the PEth as a biomarker, and then to differentiate if the marker is more than 200, this can favor ALD, PEth marker, and if it is between 20 to 200, it may favor MAT-ALD, and obviously the MAS-ALD should have less than 20. So again, but again, PEth is not available. We were just discussing, and it's not commercially available, but then few institutes may have this, but I think we may have to take the help of this in assessment. Again, a lot of drugs which are targets for MASLD, can they be used for MAT-ALD? Still, we do not have any data on this, but the one molecule which looks very promising are the GLP-1 agonist, and semaglutide does have some data. Semaglutide will help you not only in your metabolic dysfunction, but also has an anti-craving effect. So it has an anti-craving effect, so which means that it will help you in controlling both AUD as well as metabolic dysfunction, but yes, we need more data on this. So to summarize, ladies and gentlemen, what I said in the last 12 minutes is that we have an arbitrary definition of MAT-ALD today based on this Delphi consensus. This may have to be refined or this may have to change. But yes, if you look at of all these steatotic liver diseases, 85% or 90% is MASLD, 10 to 20% is MAT-ALD, and less than 1% is ALD. This we are talking of general population incidental steatotic liver disease. The clinical profile and the severity of MAT-ALD is in between the MASLD and ALD. And you can, differentiate this based on raised gamma GT, the elevated liver enzymes, and their fibrosis or the severity is, as I said, in between MASLD and ALD. Biomarkers which we use for MetALD, especially FIF4, can also be used for patients with MetALD. They have a higher risk of HCC decompensation and mortality in comparison to MetALD, but yes, less than ALD. Management requires an integrated approach, both tackling the metabolic dysfunction and AUD, and we need data whether the same drugs could be beneficial, say SARO, say SAMA, in this subgroup of MetALD, we still do not have any data, but yes, GLP-1 agonists, semaglutide has dual action, also controlling metabolic dysfunction, and also has an anti-craving effect for alcohol. But yes, as I said, I think this is maybe, we can call it as work in progress. We need more data on MetALD. These are arbitrary cutoff. As I said, the alcohol can be dynamics, whether we need to take the help of this biomarkers, and we need data on pharmacotherapy. So with this, I'll like to invite again all of you to the annual INASL meeting, which will happen in Chandigarh, 7th to 10th August. Registration and abstract submission for the meeting are open now. Thank you very much for your kind attention.
Thank you, Professor Duseja. Any questions from the floor? We can take up one.
Can I ask one question? Very nice talk, Dr. Duseja. This MetALD has two components, metabolic component as well as the alcohol. So not only the amount of alcohol which is going to affect the prognosis in these patients, the baseline metabolic liver disease, somebody having F1 fibrosis and somebody having F3 fibrosis in metabolic steatotic liver disease will also affect the progress of the liver disease.
No, absolutely. I agree with you. Not only the baseline liver disease will affect, but the kind of metabolic dysfunction they have. Somebody just having hypertension versus somebody having severe obesity with diabetes versus alcohol, or somebody just having an abnormal HDL would also be labeled as MetALD. So I think the kind of metabolic dysfunction and the baseline liver disease and the AUD, I think will be the point is very well taken, yes.
Yeah, hello. Hello. I just want to ask you one question, sir. Sometimes when alcoholic hepatitis recovers, especially alcohol-related cirrhosis, and they gain weight, they again deteriorate. So I think that should also be included, that the post-alcohol hepatitis recovery, if they are having underlying metabolic disorder, that also should be tackled.
Sorry, I can't hear it well. Can anybody, could hear anybody?
Sir, hello, there is one condition, ALD and metabolic dysfunction.
There's some kind of echoing going on. Anybody in the...
So none of us on the dais are actually able to understand the question. I'm sorry about that. Anybody can please help us? It's okay? Okay. Recovery.
Post-alcoholic hepatitis, deterioration of liver patient because of metabolic dysfunction, because that is mostly not taken care of.
Okay. I think if I got it right, what you're saying is that the natural history of somebody who has alcoholic hepatitis with metabolic dysfunction, without metabolic dysfunction. Is that right?
Yes.
Okay.
Yes.
So, again, that's a subject which is entirely different. And again, we have had 2 papers on that. Those who have metabolic dysfunction, and especially those who have alcoholic hepatitis with or without ACLF, their natural history is different. They have more severe liver disease, and their outcome, especially in terms of mortality, especially with obesity and diabetes, is worse than somebody who is without metabolic dysfunction.